As we know, the complication rate is directly related to the amount of surgery that is done. So if you were to ask me, is the complication rate for the same amount of PCI done open or laparoscopic, the complication rate will be smaller if you do it laparoscopically because you don't have the big incision. You get to move faster. And remember, the number one and most feared complication of cytoreduction and Hipec would be deep vein thrombosis with a pulmonary embolism. So, you know, if you compare the same amount of surgery, then the laparoscopic route will be associated with less complications. This is not just in peritoneal surface malignancies, but in every single procedure. The perfect example would be if you have an open cholecystectomy, you usually spend at least 1 or 2 days in the hospital. If you have a laparoscopic cholecystectomy, it's an outpatient procedure. So whenever we started this protocol, we picked up the peritoneal cancer index of 10. So that would be the criteria to convert from a laparoscopic to an open procedure. We also learned that when you do laparoscopy, everything is magnified by a factor of 16, depending on which instruments you use. And we did learn that sometimes we were looking at peritoneal mucinous deposits that look very hard to get via the laparoscopic route. And so we opened some of those patients just to find out that there were very minimal implants. The original patient that we were trying to do this also had a very large omentum. So having a patient with a very high BMI, meaning a significant amount of weight, can make an omentectomy much more complicated via the laparoscopic route.